check that the audio is.
Speakers working? Good. Thank you for the kind introduction and welcoming us. We're super excited to present at the Kenya Dental Association conference. We have Lewis and myself, who are the co-founders of Restore Dental Academy. As mentioned, we both practice in the UK in private practice, with the main focus on restorative dentistry. For those of you who are coming to a hands-on session later in the afternoon, you will also meet the wider team and the rest of our co-founders, Daisy Robinson and Nimi Dodia.
So amazing to be here. Fantastic to finally bring Restore Dental Academy to Kenya. So I'd like to talk a little bit about our ethos on teaching. We like to go through the theory and then talk about how we like to put this into practice. We like to show you our documented cases and kind of go through things step by step so that you can put things into practice in a practical sense. So today we're talking to you about minimally invasive management of discolored teeth. I think that it's important, first of all, to talk about the causes of discoloration so that we can understand the scope of practice of this lecture. So initially, extrinsic discoloration. We're all familiar with extrinsic discoloration. Extrinsic discoloration is staining. The causes, the common causes, smoking, diet-related things. The way that we manage extrinsic discoloration, effective cleaning, scaling and polishing, airflow treatments. So we've talked about extrinsic discoloration. Now to talk about intrinsic discoloration, the interesting stuff. Intrinsic discoloration, we like to break down into three parts. Pre-eruptive discoloration, such as fluorosis. Discoloration during tooth formation, such as MIH. Post-eruptive discoloration, such as pulpal necrosis and intrapulpal hemorrhage. Today, we won't be talking about post-eruptive discoloration, discoloration such as when we have pulp necrosis, such as the picture at the bottom. We're talking about intrinsic discoloration not caused by post-eruptive discoloration. So we've talked a little bit about the varying etiologies. I think that this image really nicely demonstrates the fact that you can have varying colors of lesions despite the different etiologies. So there can be a lot of crossover between distinct etiologies, but quite similar clinical presentations. The most important thing is to break things down into white lesions and to brown lesions, and then you know how to tackle them. I think it's important to talk a little bit more about fluorosis, considering its applicability to Kenya. So, what is fluorosis? What is the cause of fluorosis? The cause of fluorosis is excess fluoride at the time of enamel mineralization. There's a broad spectrum of presentations of fluorosis, from mild fluorosis, white spot lesions, all the way down to the breakdown of enamel, and everything in between, white and brown lesions. The National Oral Health Survey indicated that just less than half of the Kenyan population was affected by fluorosis, hence why I think the particular applicability to talking about it here today. I think that this image really nicely illustrates the fact that we've talked, you can have a large spectrum of the way in which fluorosis can present, but then within someone's dentition, you can have a large spectrum of clinical presentations. So for example, in this case, we have some simple white spot lesions, some white and brown spot lesions, some brown lesions, and then also some enamel breakdown, all within one dentition. So, talking about brown spot lesions, I'm going to be talking about brown spot lesions, and Ankeet's going to be talking about white spot lesions and the way that we tackle those. Traditionally, classically, the way that we used to tackle the brown spot lesions, we would begin with microabrasion. I'll talk about it in a moment why we've changed that. What is microabrasion? Microabrasion is the use of an acid, hydrochloric acid, 6%. We rub that into the tooth, removing small amounts of the enamel on the outside. This removes the superficial layers, these brown spots we're trying to reduce. A common product that we're using in this video here is Opalustro by Ultradent. As I said before, we used to commence with microabrasion for brown spot lesions. Today, we like to use home tooth whitening. Home tooth whitening is shown to be effective for mild to moderate brown spot lesions. So we like to start our process with tooth whitening, home tooth whitening. We like to use carbamide peroxide 10%. We found that to be particularly effective because it's also whitening the teeth and getting rid of those mild and moderate white spot lesions. The benefit of at-home tooth whitening with carbamide peroxide is it's been shown to cause minimal resorption. So you have the benefits of effective tooth whitening, getting rid of the mild and moderate brown spot lesions, but then also very minimal resorption when compared to the other tooth whitening gels. So this is a case, the one we were talking about before, the fluorosis with a broad spectrum of clinical presentation. How did we tackle it? As I said, classically, we'd tackle this initially starting with microabrasion, but now we've changed our protocol. We start with tooth whitening, the least invasive step. Try to get rid of as many of the brown lesions as possible. Any remaining brown lesions, we then tackle with the microabrasion, the hypochloric acid, 6%. And then after that's removed all of the white lesions, all of the brown lesions, we then place some composite. And as you can see, I think we got quite a nice result.
So as Lewis said, a lot of the time you will be seeing brown spots and white spots. We like to separate them initially, and then we'll show you how to bring it all together at the end. So white enamel defects, these are normally caused by demineralization, for example, after fixed orthodontic brackets. When you remove the brackets, sometimes you'll be able to see these around the areas. Fluorosis can also cause it, or developmental disturbances from the deciduous tooth or to the deciduous tooth on there. What I always recommend is try to get into the habit of taking a cross-polarized photo when you see these cases, because it will show you the true extent of the white spot, and you can clearly see what you're looking for without any distractions from the rest of the color of the teeth. The best way to explain a white enamel defect is when you look at the sky. On a clear sunny day like today, you'll see very, very thin wispy clouds because they've got a refractive index similar to enamel. So the sunlight is shining through and we're seeing a similar refractive index as the enamel. When you see that dense white cloud, it's full of water, so it's more dense. So the light isn't absorbed as easily. And the same thing is happening inside the tooth. When you've got a healthy tooth with sound enamel, the light is reflecting through and reflecting back. So you're seeing exactly what you're seeing in the enamel. However, when there is a white spot, it's absorbing the light because it's a dense spot. It's diffracting some light and reflecting some back. So it's actually reduced that refractive index to about 1.33, and that's the white spot that you're seeing with your eyes. When it comes to treating these cases and these white spots, it kind of is like a magic formula that was invented, and it's called ICON, which is short for infiltration concept. It's based on two key ingredients, one being a stronger acid. Now, Lewis mentioned the 6% hydrochloric acid, which we're all used to using in the microabrasion. What we found in the studies was this acid wasn't strong enough to penetrate this white spot lesion as it's more dense. And we tried phosphoric acid, which we're normally used to in our restorative treatments. However, again, that was too mild and it wasn't producing this etching pattern. So we needed a stronger acid that would actually open up this white spot and allow us to use the next molecule, which is the special resin. Most of the time in our composite resins, we're all familiar with bis-GMA. We found again in the studies that this wasn't deep enough and it wasn't strong enough to penetrate this deeper etching pattern formed and actually correct the white spot. So they added an additional monomer called TEG-DMA. And we found that this actually penetrates the lesions deeper. And the most amazing thing is it has a refractive index very, very similar to natural enamel. So when we're looking at biomimetic dentistry and emulating nature and life, it's the closest material that we have to natural enamel. When you're starting off with an icon case or treating a white spot, I always recommend you start off with a simple case like this. You want it isolated to one individual tooth. You want to be able to just to see one color, so just a white color, and still see some surrounding enamel on the tooth as well. So you can see on the bottom picture there, we've got the cross-polarized photo, and that's a kind of case that I would recommend to start off with. We had this patient present to us. She's actually a dentist, and she saw that we were doing a bit of icon, and she came to see me and Lewis. She had whitened her teeth, and you might see this sometimes. It might have happened to you as well. She wanted to fix the incisal edge of her teeth, hence she started first with whitening. However, as soon as she did the whitening, she noticed that the white spot on her upper left one was distinctively more pronounced. The upper right one still has some white enamel speckles, but it's not that obvious. So then we decided to do a course of icon treatment, and we're going to go through this step by step with you on there.
So, as Ankeet said, we're using a strong acid and we're using a hydrophobic resin. So, rubber dam is absolutely paramount when considering to do this procedure. I think that commonly rubber dam is seen as a more of a hindrance than a gain, but we're going to be showing some tips and tricks to kind of speed things up for you. The type of rubber dam we like to use latex where possible, just because of its favorable properties clinging to the tooth. We like to punch it in a way that is anatomically correct to the patient. We have templates, but sometimes we like to change things a little bit to make sure that we're getting the really, really tight hermetic seal. We like to do a four-handed technique, so we like to train our nurses to help us. That really speeds things up. And once we've placed the rubber dam, we like to invert it. The inversion really helps to get the hermetic seal. Where the lesions are in the cervical third, you may also want to consider using floss ties. Again, another aspect I think that's considered quite complicated, but we'll be showing some simple tips and tricks of how to speed that process up. The benefit of the floss ties is it just uncovers that cervical third a little bit further. So depending on where the lesion actually is on the tooth, it enables us to see just that little bit extra. This is us here doing the floss ties. It looks more complicated than it is. And what it enables us to do is just to really grip the tooth in the area. So it does enhance the seal further than just having the rubber dam, but it also just uncovers that final cervical third. So depending on if the lesion is there or not, you can uncover that. So you can see in this image, the rubber dam's in place, everything's nice and clean. You can see that we've inverted the dam everywhere. It's really, really important that things are super clean in this procedure. If you've got any water, it can absolutely mess up the resin. The hydrophobic nature of the resin does not like any moisture at all, so it needs to be super clean. Here you can see where we've exposed. We haven't yet got the floss ties in, so if you just make note of the amount of clinical crown that you can see on the centrals, and then once we get the floss ties into position, just how much extra crown you can see that cervical third. So if the lesion does extend into that area, it enables you to tackle it more effectively.
So once we've isolated the teeth, the next step we do is we apply the stronger etch. So this is the 15% hydrochloric etch, and you're going to scrub it into the tooth. We normally leave this on for 2 minutes, so that's the first cycle. In that 2 minutes, Every 30 seconds or so, you want to give it another scrub. So you're constantly activating this edge, and it'll produce this slight bubbling effect. And what we're trying to do is penetrate that lesion, that white spot. Once you've applied it for 2 minutes, you wash it off and you dry it, and you see what the result is. You apply a bit of ethanol, which is the next step in this icon process. And what this does, it actually visually simulates your final result. It quickly hydrates the tooth and dehydrates it. What it's showing in a very, very quick manner is whether you've managed to etch the white spot enough and simulate when you come to applying the resin if you've actually treated that white spot. Most of the time, you'll look at it after one cycle, nothing will happen. You've got to repeat it. So you go back to the etching for 2 minutes, you go back to the dry, you keep doing this. And from our experience in a simple icon case, normally 4 times is enough. So if we count that, that's looking about 4 cycles, 2 minutes each, with a little bit of dry, about 10 minutes. So not a long process at all. At some points in the beginning, the first time you're doing it, you will go through in your head, you're doing the cases, you're like, nothing's happening. You've just got to be patient. Like magic, there will be one cycle between number 3 and the 4th cycle, and suddenly it will have changed, and you'll believe in the product. So once you've done your etch cycles, you've done the dry cycles, you've visually confirmed that you've treated the white spot, we now have a porous tooth structure with an open enamel, and we need to seal this. This is where the magic resin comes in, the TEG DMA. So the icon resin, we're going to apply it onto the tooth, and we're going to infiltrate the lesion. You've got to leave this on for 3 minutes to make sure it's completely penetrated that lesion that we've opened up with the etch. During that time, keep applying the resin onto the tooth. So keep a wet surface. You don't want to let it dry out. And then we give a full light cure. Now with this, because it has the additional monomer, you do need to do an extended curing time. Even if you're using a strong light cure like a Velo, still give it a full 40 seconds light cure on there. We then reapply the icon resin for a further minute just to make sure the lesion is completely penetrated. Give another final cure. And then, like any restorative composite or any restoration you do using a resin, there will always be the last layer that is left uncured, known as the oxygen inhibition layer. The best way to remove this is just to do a final cure under glycerin. If you don't do that already, start doing that, and you'll notice you'll have far less staining and issues in your composite restorations. Give it a final cure under glycerin, and then because it has the additional monomer, we do need to give it a polish. We're not talking a complex procedure, just a simple polish with the 2-step spiral, a pre-polisher and a post-polisher on there. I always do the post-polish with a bit of water just to make sure it's given a really nice shine and luster on there. And you can see really in clinical, in real life, you've got a really nice result there where we've infiltrated the white spot, we've treated it on there, and she's really happy with the final result. It's non-invasive. She's a dentist. She was adamant she didn't want us to pick up the drill and drill off this white spot. She wanted it treated with icon. And then at the same time, we managed to restore the incisal edge, which we'll come on to later on there. So it really is, I would say, if you're starting off, choose a simple case like this. It's got big impacts on the front of the mouth, and it's an enjoyable treatment. There's no anesthetic or anything. It's just a bit of chair time, and you get fantastic results on there. Now, we've done a simple case, and some of you might have seen a case like this walk through your door. And as Lewis mentioned before, these cases present with varying degrees of white spots, brown spots, enamel defects. How do we treat this? And this girl was actually 16 years old, and she was referred to our clinic. She was a lovely, lovely young girl, but she was bullied at school, and you could see her confidence was really, really shot. What was harder for her was she knew she had a problem with her teeth, but every dentist she went to was reluctant to treat her. It's a little bit different here, but in the UK, it's actually illegal to whiten teeth under the age of 18. We have to get written approval and approval from our insurance companies as well. The other problem is we didn't know, a lot of dentists were reluctant to whiten her teeth because what would happen with the teeth whiten? What would happen to the white spots? What would happen to the brown spots? So when she was referred in, we discussed the case together, and we came up with a few varying treatment options. One of those would be, a valid candidate for minimal preparation porcelain veneers, but she's 16 years old. Even with the least invasive preparation protocol, we're still going to be touching her teeth. How many rounds of this restorative treatment will she have in her lifetime? The other option would be composite bonding. How thick would this composite have to be to cover those white spots? She's 16 years old, so in 5 to 7 years' time, what will that composite look like? She's going to be in her 20s to 30s and an important part of her social life and career. So we say we know that whitening works because from experience, we know that it treats the little brown spots. And as a minimum, it will at least reduce the difference in the contrast between the white spots and the tooth. So we got all of our approvals with the patient on board. So we said, let's do an extended period of home whitening. 10% carbamide peroxide, completely safe for the teeth, gentle, no sensitivity, overnight whitening. And that's the results after the 1 month. And you can really see there the brown spot has actually gone. Now, we had done some deep icon cases on individual teeth. We had never done one on so many teeth, but we thought, why can't we apply the same protocol, but just treat all of the teeth together? So as Lewis mentioned before, first thing, rubber dam. We'll show you how to do this in less than 5 minutes on the hands-on. It should be easy and slick. We apply the icon etch, and you can see here you treat all the teeth together. You don't have to do one by one. So you're not really spending any additional time. You're just putting the etch on all of the teeth that you can see with the white spots. Now, the one thing to bear in mind is this is a deep icon, and you've got to change the protocol slightly. The icon etch wouldn't be strong enough to penetrate these really deep, opaque white spots. And if we do it, we're going to be here forever because you're going to need 20 or 30 cycles. So I always recommend you do a little bit of air abrasion. Just with 29 micron aluminum oxide, there's so many now on the market, you don't need an AquaCare. There's normal attached sandblaster to the unit that will just allow you to open up the porosities. You can use a burr, but it's a little bit more aggressive. So I would start with sandblasting on the tooth. And then we repeat the etching cycle. Now, because it's a deep icon, you're going to repeat this for more times. For a deep icon case like this, I normally do it about 7 to 8 times. So you're going to repeat the etch, repeat the dry, and you should by then have removed most of the white spots. The one thing to bear in mind is we've done a deeper etching cycle and we've sandblasted the teeth, and there is a small amount of enamel removed with each cycle. In the grand scheme of things, it's still very, very minimally invasive, but we do need to be aware that once we've opened all these areas, the final resin will not be thick enough to cover these teeth, and you'll have some small little defects. So you do need to apply little bits of composite on top. Now, we're not talking about full composite veneers or anything like that, just small partial composite additions just to really make sure it's blended in and sealed all those deep areas. So visually, it just looks nice and natural again. It's really important when you are adding composite after you've treated a tooth with Icon that you follow a very, very strict bonding protocol. And this is the protocol that we follow. After you've done your last Icon resin layer and you've cured it, just give a quick sandblast again. What that will do is just replenish the resin again and give you a clean field for your next round of restorative treatment. I don't know if you guys use a sandblaster. Whoever uses an AquaCare is lucky. It's nice and clean. But if you're using the handheld units, most of the time you're full of powder, patient's full of powder, nurse is full of powder. So we'll just give a little clean off with ethanol just to clean off the teeth and remove that powder. And then use your normal etch, your phosphoric etch, just for 15 to 20 seconds on the enamel. Your bonding system, in cases like this, I prefer to use a universal bonding system like Scotch Bond Universal Plus. There's so many on the market. Just make sure it has MDP, that monomer in, which will allow you to bond to the previous resin that we've used. Once you've done your bonding system, then any composite you like the handling of. I just really like using Filtex Supreme. Just an enamel shade, something you like the handling of because it's got to blend in really well with the adjacent tooth. Make sure you use modeling brushes and just really make sure it's blended in and take your time. Give a final cure and again, just a simple polish. We'll go through all of these step by step in the hands-on. We're going to go through the full bonding protocol and how to do the composite placement as well. And it's not complicated at all. And you can see at the end of the cycle, this was the results on the day. So we managed to treat the white spots. We managed to restore those little divots and defects in the tooth. And the best thing I like to do is actually take a cross-polarized photo. There's no hiding from this photo. So once you've done an icon case, just for your own kind of objectiveness, just take a cross-polarized photo and it will show you if you've treated the case sufficiently. You will see here that the resin infiltration has actually penetrated the tooth. We've treated the white spots. You can still see the enamel. You can still see the dentine, and it's actually absorbed the tooth really, really well. And you can see from here, we've taken a girl who's 16 years old, bullied, shy, and in a matter of 1 month of home whitening, a round of icon, and some composite additions, and this is the final result, which she's really happy with on there. I actually saw her last month for her 3-year review, and you can see how well things are holding up. She's a completely different person now. She's in her first year of university. Her confidence is improved. We've not damaged the teeth at all. Maybe removed some little bits of enamel with the cycle and the microabrasion. We've kept her smile. We've kept her tooth shape. We've shown on the cross-polarized photo that we've actually treated the lesions and the white spots themselves. In terms of long-term studies, the most peer-reviewed evidence we have right now is just about 10 years. I've been doing these cases for 6 years, and I've been very, very impressed with the results. Theoretically, you're treating the white spot, you're improving the enamel refractive index, so that should be a permanent result in there. The only thing that will need maintenance going forwards is the composite, but by doing it this way, you're doing very, very small composite additions. They're easy to maintain, and we've kept her restorative options open in the future, and we've delayed any treatment for a good number of years on there.
So to summarize our full protocol of tackling the discoloration, we like to start with whitening. Carbamide peroxide 10%. The whitening deals with the mild to moderate white lesions and the mild to moderate brown lesions. After whitening, any remaining brown lesions, we then go on to microabrasion. Microabrasion is the hypochloric acid, 6%. That will remove any remaining brown lesions. Any remaining white lesions, as Ankeet went over, we move on to icon. So whitening, microabrasion, and then finally the icon. This is another case that we went through the full protocol. So as you can see, we've got some white lesions, some brown lesions, and we wanted to generally improve the color of the teeth. So we started with our whitening. There were still some remaining white lesions and some brown lesions, so we went on to do our microabrasion. The microabrasion got rid of any remaining brown lesions, and then finally icon. I think we got a lovely result. So just to cover what we'll be covering in the hands-on session, rubber dam placement, going through how to make this a slick, easy procedure for you. Combining that with the placement of floss ties, how to use floss ties, not just applicable to this kind of stuff, but also to your general restorative dentistry. We'll be covering our full icon protocol, showing you little tips and tricks. You know, we've talked about the theory, we've shown you the kind of cases, but there's lots of little things that we can give you additional information on how to use it, how you can roll it out in everyday practice, how it can be an extremely profitable treatment. I believe that our hands-on session is full, but if anyone has any interest for our future courses, we intend to be holding other courses with the KDA. So any interest, if you could please get in touch with Agnes, we'd love to hear from you. Any questions, if you could just reach out, we'll love to hear from you.
We'll also be here during the breaks and the session, so just feel free to chat with us. Add us on Instagram. We'd be more than happy to share cases together. If you guys need any help with cases you're treating, just give us a question. You know, we're so passionate about teaching and learning, and we really want you guys to take these into your practices on Monday and start applying these protocols on there. But thank you.
Thank you very much.
Thank you. Thank you. A round of applause. Thank you very much. We'll take a few questions for the two gentlemen.
Good morning. Thank you so much for the presentation. So I have a question. Does
Where is it?
icon infiltration undergo discoloration over time compared to normal composite masking?
Sorry, I didn't understand that last bit.
I'm asking, does icon infiltration undergo discoloration over time compared to like when you do masking, you'll find that there is discoloration after some time.
Exactly. So as we've seen, 3 years, that really complicated case was holding out so well. And we've got cases that I've been personally documenting for 6 years, and we've not seen any discoloration. The one thing you will notice is your composite on top may discolor. So that's when you're saying with the masking, you're adding a layer on top that will discolor over time. This is we're treating the internal tooth, and that's inside the tooth. So that doesn't discolor over time.
The icon aspect is a lot more stable than normal composite. So the actual icon seems to be keeping things looking lovely. It's the composite that you're placing on top that deteriorates, just as all composite does. So it loses its luster. So you might find you need to do some polishing afterwards, in years to come, eventually replacing the composite. But yeah, otherwise it's stable and predictable.
Uh, Good morning. Thank you for the quite interesting presentation. I was wondering, do you do that under local anesthesia or you do without local anesthesia? And then
you hear that?
Here in Kenya, we deal with quite severe fluorosis. I've seen the cases you've shared are mostly mild, very mild. Can this technique be used for severe fluorosis?
Yeah, so the first question, most of the cases I do is without local anesthetic. The only time, like we'll show you with the rubber dam, you can keep it really easy that you don't even need anesthetic to place it on. So all of these, even the deep icon cases, no anesthetic on there. The next question is with severe fluorosis cases, if you follow the step-by-step protocol with the whitening first, you'll obtain a good result with your brown spots and small white spot defects. If you still have the brown spots, you treat them with the microabrasion. If you still have the white spots, you do the icon resin infiltration. And if you have pronounced defects, then you cover it with composite. But what you're doing is really limiting and providing a beautiful treatment in a very, very minimally invasive method on there.
I think a key take-home message with it all is that it's a really nice minimal treatment, even to commence. So if you have someone with quite severe fluorosis, this is one way to start, and often you get a very good result. If it's not the final result, you've done the best for them, and you might be able to do more minimal treatment afterwards. So we have combined these cases with minimal preparation veneers. If you're doing feldspathic and it's very thin, it's letting the light come through. Even if you've improved the underlying tooth beforehand and then gone on to do the porcelain, you get a better result.
Yeah.
So it's the key is it's really great for many cases, maybe not at the top end of really severe fluorosis, but it's worth a try.
Okay. I just wanted to just comment that here in Kenya, because of the use of borehole water, fluorosis now is like a pandemic, especially in the cities,
Yeah.
because we don't have council water. So most of the people are relying on borehole water, which has a very high fluoride water. Yeah. So we are finding children now, very young, both their milk teeth and the early deciduous teeth. And these kids are actually very traumatized, even socially.
Yeah.
So what age, what is the earliest age that you can use the 10%
carbon monoxide?
Exactly,
Yeah.
to bleach.
So for us, practicing in the UK, we're dictated by indemnity and our governing body. But with prior permission, we're allowed to do it on less than 18. I think the key thing is when it's in the adult dentition, as long as you have good compliance with the patient, if the parents are on board, as soon as the adult teeth are through, you can consider the treatment. It's a personal judgment on the situation, and I'm unsure of how it works in Kenya, but
The problem you have is wearing the trace, because with 10% carbamide peroxide, which is safe to use in very young enamel, it's completely safe to use. The problem is the compliance. So the patient has to wear the whitening trays. It's not an in-chair system. So if you are struggling with that compliance, then you have to skip the whitening on there. But we'd always recommend to try with it first. From a safety perspective, it's completely safe with 10%. It's the most documented whitening gel. I wouldn't do it at that point. I would wait. Yeah.
Hi. Thank you, guys. That was very interesting and much needed in this part of the world. My question would be in regards to sensitivity post-op. What is your experience and what's the incidence that you find? Again, I would be leaning more towards the more severe cases versus the more minimal ones.
Yeah.
I was very, very surprised, especially with that case we treated without local anesthetic. She had no sensitivity after the treatment. She had a bit of soreness from the rubber dam and the gums and a little bit of the polishing with the heat. Because she had done the whitening, and most of these cases have whitened their teeth, they're used to a little bit of mild sensitivity. So straight after the treatment, we just explained to them that it might be a bit sensitive for a day or so. But all the cases that we've done, I've actually been surprised. They've said, no, it's completely fine. I don't know if that's because they've used to it because of the whitening. The treatment itself wouldn't cause any sensitivity on there. If you're doing the composites on top, the enamel defect's a little bit deeper, then you would expect a little bit of sensitivity, but it's usually transient.
Thank you. If you have any questions, you can see Dr. Ankeet and Dr. Lewis on the side. They'll be happy to take your questions. A round of applause. Thank you very much.